So left to right shunt lead to the later cyanosis. Why? Already discussed. Okay, first of all, VSD asymptomatic at birth may manifest or clinical features will come weeks later or remain asymptomatic throughout the life. Mostly self-resolved larger lesions may lead to the left ventricle overload, also can lead to heart failure. Okay, next second is a arterial septal defect. Arterial septal defect in the interarterial septum. Wide fixed split S2 sound. Ostium scandum defect most common. This is a MCQs. And primum defect rare and usually occur with other cardiac anomalies. Symptoms of arterial septal defect range from none to heart failure, okay, and distinct from patent foramen ovale in that septa are missing tissues rather than unfused. And we also discuss here oxygen saturation increase in right atrium, right ventricle, and pulmonary artery. Already discussed. Why? Already discussed. May lead to the paradoxical emboli. What is meant by paradoxical emboli? Systemic venous emboli used ESD defect to bypass lungs and become systemic arterial emboli and associated with a Down syndrome. Arterial septal defect associated with the Down syndrome already discussed in detail. And but next third one is patent ductus arteriosus, also known as in short form PDA. In fetal period, shunt is right to left. Normal is normal physiology. In neonatal period, decrease pulmonary vascular resistance. Shunt become left to right, progressive right ventricle and left ventricle, and ultimately heart failure associated with continuous machine-like murmur. This is a MCQ there. Okay, continuous machine-like murmur already discussed. Patency is maintained by prostaglandin A. Okay, synthesis and low oxygen tension. Uncorrected PDA can eventually result in late cyanosis in lower extremities differential cyanosis. PDA is normal in utero in pregnancy, okay, and normally close only after birth. Next, Eisenmenger syndrome is the outcome of VSD, ASD, and PDA. Uncorrected left to right shunt VSD, ASD, PDA increase pulmonary blood flow, pathologic remodeling of vasculature, pulmonary arterial hypertension, right ventricle hypertrophy occur to compensate. Shunt becomes right to left, causes late lead to the late cyanosis, clubbing, and polycythemia vera. Polycythemia age of the onset vary depending on size and severity of the initial right to left shunt. Okay, so this we discuss about left to right shunt and acyanotic congenital heart disease. Okay, next please. Coarctation of aorta. Coarctation of aorta, aortic nerving, coarctation में nerving. Coarctation aortic nerving near insertion of ductus arteriosus juxta ductal associated with bicuspid aortic valve in adult, other heart defects, and luminal and Turner syndrome in infants. Hypertension in upper extremities and weak delay pulse in the lower extremities, brachiofemoral delay. Okay, brachiofemoral delay with age. Intercostal arteries enlarge due to collateral circulations. Arteries erode, tips, notch appearance on chest X-ray. This is a MCQ's point. Okay, and complicate. What is a complication? Complications also write in notes. Okay, heart failure, increased risk of the cerebral hemorrhage, beriberi, and is more common in berry aneurysms and aortic ruptures and possible endocarditis. Possible endocarditis. So this is about coarctation of aorta. Now we are going to reading about congenital heart disease from right to left shunt and also known as cyanotic congenital heart disease. Cyanotic congenital heart disease lead to the early cyanosis, clinical presentation, blue babies, okay, often diagnosed prenatally or become evident immediately after the birth, usually requires urgent surgery, surgical treatment and maintenance of the PDA. Okay, and here we see five T's. TS. First T is truncus arteriosis. Okay, second T is transposition of the two great vessels. Third is tricuspid atresia, and fourth is tetralogy of Fallot, and four component here, and tricuspid atresia three flaps we discuss, and next TAPVR five letters. Okay, and this is a mnemonic for congenital heart disease which having shunt from right to left. Okay, so first of all discuss about persistent truncus arteriosis. Truncus arteriosis fail to divide into pulmonary trunk and aorta due to failure of aorticopulmonary septum formation. Most patients have accompanying VSD. Okay, next, transposition of great vessels. Aorta leaves right ventricle anteriorly, pulmonary trunk leaves left ventricle posteriorly. Suppression of systemic and pulmonary circulation not compatible with the life unless a shunt is present to allow mixing of blood. VSD, PDA, or patent foramen ovale. Already discussed in greater detail, but here MCQs due to failure of aorticopulmonary septum to spiral, and MCQs here egg on sting appearance on chest X-ray is a hallmark of transposition of a great vessel. Without surgical intervention, most infants die within the first few months of life. Next, tricuspid atresia, absence of tricuspid wall, hypoplastic right ventricle requires both ASD and VSD for viability. Next, tetralogy of Fallot caused by anterior-superior displacement of the infundibulum septum. Most common cause, early childhood cyanosis. This is the most common cause for the early cyanosis in the childhood, and here is four component of tetralogy of Fallot. One is pulmonary infundibulum stenosis, most common, important determinant for the prognosis. And if the pulmonary stenosis is less, then the prognosis is good. If the pulmonary stenosis is more, then the prognosis is less. And right ventricular hypertrophy is a second component, and boot-shaped heart on chest X-ray is a hallmark of tetralogy of Fallot. Next is a third component overriding aorta, and fourth component is VSD, ventricular septal defect. Pulmonary stenosis forces right to left shunt flow across VSD, right ventricle hypertrophy, TET spell, episodically cyanosis of the skin. Okay, often caused by crying, fever, exercise due to exacerbations of right ventricle outflow obstruction. So after that, tetralogy of Fallot patients and childs lead to habit like squatting, and in squatting increases systemic vascular resistance, decrease the right to left shunt, and improve to the cyanosis. Okay, associated with the DiGeorge syndrome, and DiGeorge syndrome is a mutations with the 22q11 syndrome chromosome. So, okay, next please, total anomalies pulmonary venous return. This is of total five letters, and pulmonary veins drain into the right heart, circulation, systemic vascular circulation, coronary artery, sinus, associated with ASD, sometime PDA to allow for right to left shunting to maintain carbon monoxide. Next, abstain anomaly. This is important for exam point of view, and displacement of tricuspid wall leaflets downward into right ventricle, artificially arterializing the ventricles associated with tricuspid regurgitation. accessory conduction pathway right to left heart. From here, and this is most important exam point of lithium exposure in the pregnancy or utero. Okay, and here for exam point of view, abstinence anomaly is important, tetralogy of Fallot is important, and great vessels is important for exam point of view. So this is all about congenital heart disease. Thanks for your attention, for your listening. Lecture dismissed till tomorrow.